when you come to complex congenital work, you can have the position of these conduction bundle varying in position, and you may end up inadvertently injuring it. So what we have here is a bovine heart. And when we start off any anatomical specimen analysis, I hope you can see this is flickering. If you can you stop the flicker? Yeah, that's better. Yeah. Hope you can see it. You can see the structures? Is it clear to everyone? I think you can switch off more of the lights. You can switch off some of the lights in the auditorium also, so that the visibility. So this forceps that I have placed is between the SVC and IVC. So you can see that this structure is placed between, this is the IVC, and this is the SVC. This is the right atrium. And this is the right atrium, this is the right atrial appendage. So if I take a slit, if I make a slit between the SVC and IVC, what I'll be doing is essentially I'll be opening up the one of the problems with surgeons is that, over time you get used to using loops. So without loops, it becomes quite difficult to visualize. So anyway, what I'll do is I'll open the I'm opening the right atrium. So essentially we've So you open the SVC and IVC. So what you're going to see next is the intraatrial septum. So you identify the intraatrial septum mainly by seeing this puckering. This puckering is called the fossa ovalis. This shows how the blood was flowing in utero. So the blood that came to the right atrium has to pass through this foramen ovale and then go into the left atrium, which is on the other side. So this is the intraatrial septum. And then on this side, what you will see is the tricuspid valve. Could you hold this? So the first valve that you will see is the tricuspid valve. So this is the tricuspid valve showing it's got 3 leaflets. This is one leaflet. This is another leaflet. This is called the septal leaflet. This is called the anterior leaflet. And this is called the posterior leaflet. The septal this is altogether, this is the anterior leaflet. This whole thing is the anterior leaflet. You can see. I think the light needs to be very clear. You may have to move your head a bit, I think, so that the light comes. You're able to see? Is it clear? Is it clear, Balu? It's clear. Okay. So you can see this anterior tricuspid valve. Leaflet, posterior, and septal. So in congenital heart surgery, the most important thing is to understand the right ventricular anatomy, because a lot of our work is dependent on right ventricle. So the standard incision to open the right ventricle is you cut across the anterior septal valve and anterior tricuspid leaflet to the apex. So we are cutting this to the apex. We've cut it to the apex here. Your head is coming. So we're cutting to the apex, and from the apex, we will cut it to the pulmonary artery. This is the pulmonary artery. So we will cut it to the pulmonary artery, and we've opened the right ventricle like a book. So this, what you see is the right ventricle, where this is the tricuspid valve, and then this is the pulmonary valve. So always remember that the anatomical orientation of the ventricles is the left ventricle is a globular mass like this. And then the right ventricle, if you take this as the my left hand as the left ventricle, and then the right ventricle is a structure wrapped onto the left ventricle. So it has an inlet, which is the thumb, and it's got an outlet, which is the pulmonary artery. While the left ventricle is something like this. It's got its inlet here, it's got its outlet here. So it'll have its inlet here, an outlet here, and then this is the way the heart is arranged. So LV is globular, while the RV is a wrapped around surface. There's no view where you can, while doing an echo or while examining, there's no view you can, align the probe in, cut these two in the same way, in the same angle. So this is like this, the blood flows like this and comes out like this. That when we open the LV, I'll describe that more. So one of the important things to understand in the right ventricle is, of course, bovine hearts, human hearts have a bit more complex anatomical structure in that they will have a prominent, I think it's out of power, battery. Yeah. You can shine your mobile. Torch. Maybe it better. Take this. You got it? Okay. Okay, good. So you can see the mic also. So this is the attachment of the tricuspid leaflets. So I'll detach it from the tricuspid leaflet. And this, you can, under the tricuspid leaflet, you may be able to see an area. I'm not sure if you're able to appreciate that. Are you able to appreciate this white structure? This white structure here. You can see that white structure there. I hope it's clear. So that is something that you call the membranous tissue. That's called the membranous tissue, and that's where the bundle is going to be. The bundle usually passes along the posterior border of the membranous tissue. So you have the membranous tissue here, and between the membranous tissue and the muscle, this is where the bundle will actually pass. So that's the marker for your conduction bundle. Here, to identify the node, so the node is probably like, it's not like a seed. The AV node is not something like a seed. It's something like a neuronic structure. It's got a lot of dendrites like structure, and then all this come together and then converge at this point. And so how you identify the node is something that's in the triangle of Koch. The triangle of Koch is it's a triangle bounded. The base is the coronary sinus. One side is attachment of the tricuspid leaflet or the tricuspid annulus, and the other side is something called the tendon of Todaro, which we may see when we cut open. So if you have a triangle like this, at the apex of the triangle, the AV node will lie at the apex of the triangle. And then this immediately converts into the bundle. It immediately converts, it transitions into the bundle, and then from there it goes down. The moment it comes down here, it splits into two. It splits, one side goes into the LV, which becomes the left bundle, and the one side comes to this, which becomes the right bundle. So in a VSD, most usual position is the VSD will open up here. So the bundle will be in the posterior margin of the VSD in cases of perimembranous VSD. So when VSD occurs in this region, that's when you call it a perimembranous VSD. So this will be that's going to the pulmonary valve like this. And then the pulmonary valve, it goes into the MPA. You can see this, what I cut open here is the pulmonary valve. is the three sinuses of the pulmonary valve, and then it goes into the confluence, and from the confluence you can see two holes there, which are basically the left pulmonary artery and the right pulmonary artery there. Those are the two holes. You can see that there and see the left pulmonary artery. Now what you see here is the PD actually. What you see here is, it's not the PD anymore, it's the ligamentum. So this, if you cut open, this is the ligamentum. So if you divide the ligamentum, you will get the PA free. You can get the PA free now. So the PA will come out. Hold this. So the PA will come out. I know this doesn't look like surgery, it's more of like butchery, but still, essentially surgery is nothing but refined butchery. So, so what we have here is now the PA. So I'll just dissect out the PA from the rest of the areas, so that you can have a. This is the, so you got a place below the PA and above the left atrium. This is the left atrium. So you got a place like this. This is called the, it's called the transverse sinus. So transverse sinus is actually a natural plane. So we can use that natural plane and release the PA. So once you release the PA will come off as a independent structure. So you see, sometimes it can get really confusing. And when you start harvesting, finally one day you'll find that you've already cut some valve which you really didn't intend to cut, because the orientation can get really confusing at times. So I've just, oh, by the way, before I massacre the specimen, to give credit to my to the adult surgeons also. Cardiac anatomy is just not congenital heart surgery. So here you will have the, this is the aorta, as you know. Here you will have the, it's a bit frozen here, so okay, I'll show the coronaries later. Okay, so this is the PA now, which has come separately. So you can actually develop a plane between the PA and actually take it out. That we can take it out in the next step. So that is with regards to the right atrium. A brief look into the right atrium. The pulmonary veins, the left atrium starts, we always dissect in terms of how the blood flows. So these are the right and left pulmonary veins joining the left atrium there. So what we'll do is, we'll just open the right and left atrium completely. I mean, we'll just join between the right and left pulmonary vein, like how you do it for a transplant, and then we'll extend it into the appendage. That's the left atrial appendage. So that's a left lateral appendage into which we've cut, and there inside, what you see is the mitral valve. You can see the mitral valve like this. So this, the one closer to the aorta will be the anterior mitral valve. So AA, aorta, the anterior mitral valve, and here posterior mitral leaflet, anterior mitral leaflet and posterior mitral leaflet. So we'll have a look at them. So that's essentially the anatomy between the from above, essentially from above. So we'll just have a look at it from the ventricular side. So for having a look at the ventricular side, you have a blade. Can you just open this blade? So for having a look from the ventricular side, what you need to do is, we just identify the LAD and start chopping from the apex. So if we go parallel to the so we are just opening the LV. This is a a standard incision to expose the LV. So once we open the LV like again like a book, so what you will see LV, this is from below. These are some things, these are not attached to the valves. These are called false tendons that are attached between the free wall and the so that is the structure of the LV. So that was a big clot there. So once I'm not sure if you're able to visualize that. So this is a mitral leaflet that you're seeing, and cut a bit more because I think there's no enough light for it. So once this is a mitral leaflet, and this is the mitral opening. So you can see this. This is the mitral opening. This is the aortic opening. You see that both are in same line. Like now, unlike the RV, the LV has both these openings. So this comes into the aorta. You can see that this comes into the aorta here. So both are in same lines. You can just place a finger like that, and both of them will go like that. So this I think it's too deep, and I don't have a bright light. Can you just put a bright light here to understand this? That phone light. So okay, with whatever light we'll have to see this. So that goes into the aorta. The blood flows from the MV like this, from the mitral valve like this, gets squeezed and goes straight into the aorta. So we'll just detach the. If you notice something peculiar about the mitral leaflets, you'll see that. See, this is a septum that we are seeing. This is the septum. If you can see that, this is the septum. This is the free wall. This whole thing is the free wall. You see, none of the chordae from the mitral valve will ever get attached to the septum. That's why mitral chordae are considered septophobic. That means if you are imaging a ventricle where you're seeing the caudal apparatus being fixed to the septum, that means you're probably seeing the right ventricle. So while here, if you see, you'll see that this is the tricuspid. The tricuspid chordae are all attached to the septum. This is the septum. So tricuspid chordae are considered septophilic, and mitral chordae are considered septophobic. So it's an easy way of identifying. Sometimes you can have a very difficult situation where you're really unable to identify which ventricle or which leaflet it is in some complex congenital diseases. So that's one easy way of doing it. So I'll just release these chordae so that we'll have a better view. And what you see here, this gap, this is what you call the LVOT. That's the left ventricular outflow tract. So we'll just approach it from above. See, this, unlike human branching, this branching is called the bovine branching. So what happens is, this is called the bovine trunk. Bovine trunk is in which all the blood supply to the brain goes through one single trunk. It's got only two carotids. Actually, unlike it's a misnomer that what we call bovine trunk in humans. In bovine trunk in humans, we'll always have the bilateral subclavians also. In bovine, there is no bilateral subclavian. It's just bilateral carotid, actually. So when we used to do initial animal experiments, we used to end up with a strange problem. We used to, when you view from above, you end up seeing the, you just see like this only, because you do it through a right thoracotomy. You will see it like this, and then you will always think that this is the aorta. We used to just cannulate this, perfuse only the brain, and then in the end, the animal used to be dead. We realized this, that we had to go down and clamp. We had to isolate this and clamp. So this is the anatomy from which this bovine trunk came. So we'll just release the bovine. We'll just cut open the aorta so that we can have a description of the coronary anatomy. So now we'll see from here. Hope you're able to see it. You may require more light. That's the ascending aorta that I'm transecting, so that you can have a better view of the aortic valve. So those are the 3 leaflets of the aortic valve. They're usually not brownish and reddish like this. They're usually, sort of whitish structures. So from here, let me see if I can. So from here, if I, do you have a probe? Probes? So from here we have two ostia. One is the left that goes like this. Yeah. One is the left that goes coronary ostia that goes like this, and goes into the left coronary, and then we've cut it there. So the proximal part we've cut it. So see, that's the LAD. It's going into the LAD now. You can see that. So that's from where the left coronary sinus arises, from the posterior, and from here will be the right coronary sinus. Okay, so from here is the right coronary sinus. I'm not sure if you will be able to see it. So from there is the right coronary sinus going there, and here is the left coronary sinus. We can open it more and see that. Yeah. So we'll open up. We'll just take off. We're just removing the. So it's already a large heart, so you really don't want to do any procedure on this. But one of the important questions that routinely come for your MCH or exams is this: what are root enlargements? So there are 3 ways you can enlarge the root, by cutting into either of the 3 sinuses. So this is the non-coronary sinus. This is the, I'm not sure if it's that clear with this light. So if you enlarge into the non-coronary sinus, it's called the Nix-Nunes procedure. The Nix-Nunes. Or now there is a newer modification. What is it? The Boyang? Yeah, the Boyang also. So if you enlarge into this, but stay above the annulus, it's called the Nix procedure. So you can enlarge the annulus like this, remove this valve, and then place a patch here so that the whole annulus is enlarged, and that's called the Nix procedure. So if you enlarge into the left coronary cusp, which now most people don't actually do. So what you have to do is, this is a left coronary. You have to cut to the right of the left coronary. You go to the right of the left coronary, open up like that, and open onto the, now you got the anterior mitral leaflet there. We've removed the roof of LA, and you can see the anterior mitral leaflet there. So if you cut into the anterior mitral leaflet, then again that's one way to enlarge the annulus when you have small annulus. That's called the Menugian procedure. So that is one way to enlarge. The most common what pediatric use is the Kono procedure. The Kono procedure is in which you enlarge to the right coronary cusp. So you go to the left of the right coronary. So you got the right coronary going like that. You hold like that and then cut into the. So before you do that, you have to make sure that you split way down into the pulmonary annulus. So basically, because this pulmonary annulus arises separately, you should always remember that pulmonary annulus is something, see, you can, it's a freestanding infundibulum. So you can actually raise the pulmonary annulus out as a separate structure. That's the basis of Ross procedure. So the basis of Ross procedure is that you can you hold this? So you see that that's the pulmonary artery coming off separately. So you can actually take the pulmonary artery out separately as a separate trunk and then put it onto the aortic side. So now I'm going to harvest the, what do you call, the pulmonary annulus. So you can see that I'm harvesting the pulmonary valve, the whole valve itself I'm harvesting. So without, as an individual freestanding valve, see, I can harvest it. So goes like that. So here, when you harvest the pulmonary annulus onto the left side, you should not cut the coronaries. So yeah. So since it's frozen, it's a bit different. So yeah, of course, I've cut the left coronary. So actually, you can harvest out the whole. So if it was closed like this, you could harvest out the whole pulmonary valve like that and then suture it. This is the basis of Ross. So you got, this is something called a autograft. You harvest the pulmonary root separately. So in Ross Kono, actually we did that so as to facilitate Ross Kono. So not Ross Kono, just a Kono procedure. So in Kono procedure, what you do is you go to the left of the right coronary, and then you see that you go to the left of the right coronary, and if you keep cutting, you'll always go into the septum. So you just cut into the septum like that. I mean, the valve shouldn't be there in a real AVR. So you cut like that, you cut like that. See, you get a big annulus. You patch this up, and then you can put a thing. So now you can see the coronary orifices clearly. This is the right coronary going this way. This is the left coronary, which we took off with the Ross autograft. So that is that. That's the left coronary there. That's the right. So that's just a basic introduction to the heart. So if you see, fundamentally like how we were taught. We've explanted the tricuspid also. So let's just hold this. Let's hold this. So if you see from here, before if we had seen that, you see these three valves. Can you see? This is a tricuspid valve, this is a mitral valve, this is the aortic valve. These three valves are all joined together. They're all in one group. And it's only the pulmonary valve that's actually standing away. So these three valves are almost always together in a normal heart. This changes in TGA. In TGA, the pulmonary artery will come here and the aorta will stand away. So where all these three structures are joined together, that's where the central fibrous tendon comes here. Here exactly is the central fibrous tendon. And where you see the central fibrous tendon is where exactly the bundle will be. So here, from this side, you'll see the bundle. So if you actually take that membranous septum that we saw earlier, I'm not sure if you're able to, if you can shine a bright light from that side, you'll be able to see. Okay, it's not the same with. So anyway, that's how. So you can actually cut the aortic valve and enter into the mitral. You can cut the aortic valve, enter into the tricuspid also accidentally. This way you can go and enter into the tricuspid. So these are the structures that are in close proximity, and you should bear in mind when you dissect structures. Hope that's enough. Isn't it? Do you have any particular things you would like to clarify? Okay. Anything else?
Can we have the concept of fibroskeletal system enlargement of the annulus?
The aortic annulus.
I mean, during MR where the annulus dilates.
Yeah, okay. So it's reasonably chopped up heart. That's the mitral valve. So you can hold this. So the moment the fibroskeleton is basically a structure that goes between the aorta, the mitral. This is the basic aortomitral curtain. You can hold this also. So this is the basic aortomitral curtain. This is the basic aortomitral curtain here. So, and this is a muscular region actually. And this is a fibrous region. So when the MR occurs, this part is going to dilate, while this portion between the aortomitral continuity, which is fibrous, will not dilate. So as the annulus dilates, it will become a shape like this, while this part will remain constant. So that's why annuloplasty is not just a technique of reducing the annulus. It's also a technique of actually reshaping the annulus. You got to reshape it back to its original form, rather than just the concept that you just need to reduce in diameter. So that's why if you use a plain circular annuloplasty ring, like how some people were using, you'll always find that the posterior part is dipped down and you will have a problem. You don't want to make it into a circle, you still want to make it into an ellipse. So that is a concept regarding the annular dilatation in mitral. So the annular dilatation in tricuspid, again, this part, the free wall part, that's what's beyond the aorta. This free wall part is what will dilate. The membranous area to the aortic area, that area is not going to dilate. It's going to remain the same. This area, the anterior, posterior regions will dilate much more than the septal and the aortic regions. So that's the way. So the ring again will be in that shape. So you need to. But the rings in tricuspid are made in such a way that you avoid the suturing on the conduction tissue area. This is the conduction tissue area. Not sure if you can shine a light from behind, you can see the membranous tissue. You can shine a light from behind. No, not from here, not from here. From that side, from that side. No. I'm not sure if you're able to appreciate it, but yeah, it's raised. You can make that out. Yeah, that's the central fibrous tendon. That's a membranous tissue there. Anything else? Usually there is much more RV surface anatomy, ventricular septal anatomy, which you can actually learn by seeing the septal band dividing into the anterior limb of the TSM and posterior limb of the TSM and the VIF. But unfortunately in this specimen there is not much of RV trabeculations which you can demonstrate. It will be more of imagination rather than true description. Okay, anything else? Anything else, Dr. Amrish? This is also the way we split open the valve in supravalvular AS. So when we do a Brahms iontoplasty, this is exactly the way we will split open. We don't split so deep, we just split only up to the mid sinus of Valsalva level. We don't go beyond the sinus of Valsalva level. That's the way we do it. Anything else, Dr. Amrish?
Thank you, Dr. Thomas, sir, for a wonderful illustration on anatomy of heart that enlightens the young surgeons to appreciate the beauty of art. Thank you so much, sir.